Something we misinterpret often with new medical drugs is the blood-brain barrier. The blood-brain barrier is really our biggest enemy in that, of course, it's our biggest friend, but it's also our biggest enemy when it comes to oncology. IPAX-1 study, which was of course the phase 1 study on TLX-101 in the recurrent setting of glioblastoma, so patients with a recurrence or refractory disease that got TLX-101, which is iodine phenylalanine combined with external beam radiation therapy. IPAX-1 study is really enthusiastic for GBM patients because, let's be fair, the survival rate is just 20% in 2 years' time after diagnosis, so it's a very big unmet need in the medical community. About 95% of our small molecules does not pass the blood-brain barrier. Large molecules don't pass at all. So there's just a very short window of peptides and molecules that truly do pass that blood-brain barrier. The blood-brain barrier has the LAT transporter, so the large amino acid transporter, and that allows amino acids to pass the blood-brain barrier, and that LAT transporter is also upregulated in GBMs. So we use that LAT transporter, and in particular the subtype 1 and subtype 2, that nicely transfers the radiopharmaceutical over the blood-brain barrier into the GBM, and where it then gets trapped. And it stays there for quite a long time. So based on the images I saw in the IPAX-1 study, in which we did multiple time point imaging up to 7 days after treatment, it stays there for at least a week, probably even longer. So that's very beneficial for especially something like iodine-131, which has a very long half-life of 8 days, that you have long retention and long irradiation of the tumor from the inside.